Hello, welcome to Pathogonia. This is Jay Huang. Today we are going to talk about medical liver using awesome Kurtz notes. This is in request to one of our subscribers, Mia, so shout out to Mia. And before we begin, if you already haven't been to Kurtz Notes, you've got to check out his website. It's great for medical students, pathology residents, and staff alike. He's got his About Me page as well as useful links for us as well. And without further ado, let's begin. Before we begin, I just want to say this is gold. Medical liver to me is really hard, and to have a succinct but very important nuggets of medical liver that is Kurtz notes here has been really invaluable. So without further ado, steatosis, steatohepatitis. They're both the same disease process and both lead to fibrosis. However, steatohepatitis goes faster. And how do you differentiate? Well, steatosis is just abnormal accumulation of fat, as you can see here. Steatohepatitis, you need the eosinophil bodies and or ballooning, which indicates active lobular injury. Portal infiltrates may be present, but are usually mild. And if they are severe, consider your other differentials, which we will talk about soon. For your ballooned hepatocytes, and again, if you see this, that indicates steatohepatitis. They're enlarged such that they stand out with no fat and thin wispy cytoplasm. They're most often in zone 3, which is where the central vein is. Macrovesicular versus microvesicular steatosis. So what is this? So here is an example of macrovesicular. It represents a change in lipid metabolism. And the predominant pattern is the nucleus pushed to the side by usually a single medium to large size droplet, as we can see here. And it's okay to have smaller droplets here and there. But if you see them as a diffuse change, these smaller droplets, you want to consider microvesicular steatosis, which represents mitochondrial injury usually. And the nucleus remains central as opposed to eccentric, with innumerable fine fat droplets. Now, quantifying fat is helpful to us and to clinicians to estimate the extent of your steatosis. So you want to average over the entire specimen and report rounded to the nearest 10%. And they're often found in zone 3 first, where the central vein is. So less than 5%, grade normal, 5 to 33%, mild, 34 to 66%, moderate, and greater than 67% severe. Fibrosis. So fatty liver disease can cause pericellular fibrosis, where it goes around, wraps around the hepatocytes, as well as pericentral, where it's zone 3, where it wraps around the central vein. And this is where the most fat is. And that progresses to portal, which is zone 1, and pericentral fibrosis. And this can lead to bridging fibrosis and cirrhosis. And once cirrhotic, there may be relatively little fat. So fat accumulation can lead to cirrhosis, but once you're cirrhotic, there might be little fat. Alcoholic hepatitis. This is hepatocyte injury and inflammation resulting from chronic alcohol consumption. Serologically, you'll have traditionally AST over ALT ratio typically greater than 2. Micro findings are steatosis, but findings that favor alcoholic hepatitis is you have more hepatocyte ballooning. You'll see more of the mallory denk bodies. You can have steatosis, but how do you differentiate that from alcoholic hepatitis? Well, besides serology, you're going to see more hepatocyte ballooning. You're going to see more neutrophilic lobular inflammation, and you're going to see more mallory denk bodies here. You can get lobular cholestasis and more diffuse pericellular fibrosis, but look for that lobular neutrophilic inflammation, that many mallory denk bodies, as well as many balloon cells. And what are mallory denk bodies? These are pink ropey cytoplasmic inclusions, and it's ubiquitinated cytokeratins. And these cells also lose expression of CK8 and 18. Non-alcoholic steatohepatitis. This is associated with metabolic syndrome, including obesity, type 2 diabetes, dyslipidemia, hypertension. You can see steatosis, as you can see the fat droplets here. You can see ballooning. Look at that balloon cell. You see lobular lymphs as you can see here, and newts. The exception is pediatric patients where the inflammation is more zone 1 or portal. You can see acetophil bodies and pericellular fibrosis. And sometimes adults have mild portal inflammation, which generally are mainly lymphocytes. And you can grade stage using NASH CRN system. So for fibrosis, our institution gets a trichrome so we can better visualize the fibrosis and its relationship to the structures of the liver. So you can have 0 through 4, 4 being cirrhosis, 3 bridging fibrosis, zone 2, or 2 is zone 3 sinusoidal fibrosis and portal fibrosis. 1C is portal fibrosis only, 1B is moderate zone 3 sinusoidal fibrosis, 1A is mild zone 3 sinusoidal fibrosis. And then we talked about the steatosis for grading, as well as you want to look at lobular inflammation at 20x and check for how many on average foci you see lymphocytes, and then whether there's hepatocycular ballooning. As you can see, there's a little bit of subjectivity because mild and few might be different from one person to another, but that's 1, and moderate to marked is 2. And then once you have the numeric score, you want to sum the individual components, and the maximum will be 8. Wilson's disease. This is mutation of copper transport protein, ATP7B gene, and that leads to the inability to excrete copper in bile. And so what's going to happen is you're going to accumulate copper in your hepatocytes and other cells in other tissues. Clinically, you can have acute or chronic liver disease. You can have that bronze diabetes with hypogonadism. You can have neurologic psychiatric findings, hemolytic anemia, plus or minus Kaiser-Fleischer rings, which we've learned in med school. Serologically, you'll have low ceruloplasmin, increased urine copper, AST-ALT ratio greater than 2.2, and alk-phos total bilirubin less than 4. The micro description, it's variable. You can have steatohepatitis with possible mallory denk bodies, which we talked about, and glycogenated nuclei. And you can have later chronic hepatitis. So when you're considering diagnosis, send block for copper quantification. Total parental nutrition. You can have variable steatohepatitis or cholestasis depending on your age. So if you're an infant, you can have more cholestasis. Kids, you're in between, and for adults, you can get more steatosis, steatohepatitis. Other causes of macrovesicular steatosis. Drugs. Drugs is a very big one and includes amiodarone, glucocorticoids, methotrexate, tamoxifen, and certain chemo agents. Other conditions including malnutrition like marasmus or kwashiorkor, hormone alterations, hypothyroidism, elevated cortisol, growth hormone deficiency, cystic fibrosis, and lipodystrophies. We discussed microvesicular steatosis and how that's a sign of mitochondrial damage, and that's because the finely divided fat cells accumulate in the cytoplasm. And you want to call this when it's diffuse, not just focal. And when you see this, your differential is more limited. It includes Reye syndrome, inborn errors of metabolism, drugs, toxins, acute fatty liver of pregnancy. Portal tract chronic inflammation, so your zone 1 chronic inflammation. Your basic differential diagnosis is viral autoimmune drug. Chronic hepatitis C. Approximately 90% develop chronic infection. It is bloodborne, and antibodies to HCV indicate exposure, and detection of HCV RNA indicates persistence. And you have newer meds like Harvoni, which are highly effective, and then it is slow, silent, progressive disease over decades, leading to cirrhosis and an increased risk of hepatocellular carcinoma. And you can see variably dense portal lymphocytic infiltrates. You can have periportal interface activity, so around the portal tracts, kind of the inflammation interfacing to the adjacent hepatocytes. So if this is the portal tract, it kind of interfacing past it. Scattered lobular collections of inflammatory cells with or without acidophil bodies, portal lymphoid aggregates, and rare plasma cells allowed. there's a lot of plasma cells you might want to consider autoimmune hepatitis. Viral hepatitis, is it acute or chronic? And we often use the clinical definition, which is elevated liver enzymes greater than or equal to 6 months. If you see fibrosis, that's a sign that there is chronic damage. If you see diffuse moderate lobulitis, it can mean acute or acute on chronic. And you want to stage viral hepatitis using the BATS Ludwig, Ishak, Schauer, or MET-AVR systems. Chronic hepatitis B. 10% develop the chronic disease. It is bloodborne as well. You'll have portal chronic inflammatory infiltrate with interface activity, lobular hepatitis like we have mentioned with chronic hepatitis C. You can see, however, what's more unique, ground glass inclusions and sanded nuclei. And the hepatitis B surface antigen means the patient has been infected, and hepatitis B core antigen means the virus is actively replicating. Fibrosing cholestatic hep B. This is a variant with more progressive, and it's a worse disease, usually in the immunosuppressed state, such as a post-transplant, and you can have extensive cholestasis, bile ductular reaction where you have more than one duct and multiple ducts in the same portal tract, hepatocyte swelling, and fibrosis. Hepatitis D, remember from med school, it requires hepatitis B and can lead to acute on chronic hepatitis. Autoimmune hepatitis, it's a strong female predominance. You'll often have a marked elevated AST, ALT. Serology, look for your positive anti-smooth muscle antibody. You can also have ANA, LKM1, and elevated IgG. Histologically, look for dense portal infiltrates with marked interface activity. If this is the portal tract right here, and this is the lobule, you can see it kind of interfacing with the hepatocytes. And you'll often have lymphs and plasma cells. You'll have lobular injury, and you can have regenerative rosette formation. And it can have an overlap with primary biliary cholangitis. Criteria for autoimmune hepatitis. So the stronger the amount of autoantibodies for ANA or SMA, the higher the likelihood the patient has autoimmune hepatitis. Remember that the higher number, 1 over a higher number, means there's more antibodies. It takes longer to dilute it where it's gone. Serum IgG, elevated means you have a higher chance of AIH. Histology, absence of viral hepatitis. So a score greater than or equal to 6 is probable AIH, and greater than or equal to 7 is definite AIH. And just to recap, histology, the typical is lymphoplasmacytic interface hepatitis. Remember, extending into the lobule from the portal tract. Regenerative rosette formation, and you can have emperipoiesis, and is compatible with chronic hepatitis with lymphocytic infiltration without all the features considered typical. Atypical, signs of another diagnosis such as steatohepatitis. Graft versus host disease. It's usually a post-stem cell transplant where the transplanted immunocompetent T cells attack the new host, saying this tissue is foreign, these cells are foreign, we have to attack, they're invaders. So it involves the skin, liver, GI tract, and that can lead to rash, elevated LFTs, diarrhea, and vomiting. Look for bile duct epithelial injury, where you'll see lymphocytic inflammation, withering and dropout of your bile ducts, mild portal inflammation, and possible endothelitis. Rejection, which means immune-mediated inflammation and damage in transplanted liver, causing injury and hampering its function. So you can have T-cell mediated rejection, formerly called acute cellular rejection, and you will have histologically mixed portal tract inflammation. You can have lymphs, you can even have EOs and other inflammatory cells. Look for bile duct damage and inflammation, and endothelitis, which is inflammation of the endothelial cells. Plasma cell rich rejection, formerly de novo autoimmune hepatitis. You'll look for portal and or central plasma cell rich greater than 30% infiltrates and lymphocytic cholangitis. Remember, you want to make sure that the original disease is not autoimmune hepatitis. Otherwise, it could just be a recurrent autoimmune hepatitis. Chronic rejection. Look for bile duct injury, which over time can lead to eventual loss and paucity. You also often lose your hepatic arterioles and chronic vascular damage with foam cell arteriolopathy and luminal narrowing, as you can see here. Antibody-mediated rejection. Look for portal vascular dilation. Remember, zone 3 dilation, endothelial cell hypertrophy, and arteritis. And it's often edematous portal tract, zone 1, and cholestasis. C4d IHC, C4d being part of the complement cascade, shows greater than 50% staining of vein and capillaries, and you'll have a positive serum donor-specific antibody. Lobular injury, this is where I think of like zone 2, where your hepatocytes are. They're not in the central vein, they're not in the portal tract, just a lobular injury. That indicates an acute process, too injurious to be chronic. Often, as such, you'll have very high transaminases. Now, let's define what lobular disarray is. That's when the normal plate structure of your hepatocytes are disrupted. Lobulitis, this is when your lymphs attack your hepatocytes in the lobule. Acidophil bodies, these are apoptotic hepatocytes. So, acute viral hepatitis, usually this is due to hepatitis A or B. Remember, A and E are spread by fecal oral. The vowels hit the bowels. The diagnosis is confirmed with serology or serum PCR. So I haven't received any real cases of acute viral hepatitis because of serology. But if you do receive one, you would see lobular damage and disarray, diffuse lobular inflammation, hepatocyte ballooning, swelling, hepatocyte necrosis and regeneration, and you can maybe see mild portal and periportal inflammation, but you shouldn't see fibrosis because this is acute. Drug reaction. There are two chief mechanisms: intrinsic, which is dose-dependent, predictable, less inflammation, more necrosis, versus idiosyncratic, which is your majority of cases. It's not dose-dependent, more inflammation. And herbal and botanical drugs are important but often overlooked cause of hepatotoxicity. There are very diverse histologic findings, so drug reactions can mimic many other disorders like autoimmune hepatitis, so it's not a bad idea to include in your comment section your differential includes drug reaction. And if a patient is on a particular drug that you haven't heard about or you're not sure what the interaction is with the liver, check out this website, Idiopathic Neonatal Hepatitis, otherwise known as neonatal giant cell hepatitis. You'll have neonatal jaundice with hepatomegaly, elevated total bilirubin and conjugated bilirubin, and variable AST/ALT. This is a diagnosis of exclusion. You must exclude biliary atresia, which has the treatment is the Kasai procedure. Loose association with hypopituitarism. And histologically, you're going to see lobular disarray with prominent giant cell transformation. And you can have absent to mild lobular inflammation, despite the name, canalicular and hepatocellular cholestasis, and minimal portal tract changes and preserved bile ducts. So you can see some of the bile here, bile pigment here. Cholestasis/biliary. Labs, you'll have elevated alkaline phosphatase, GGT, and serum bilirubin. You can highlight the bile ducts with CK7 and CK19. And you often see increased copper deposition in the periportal hepatocytes with cholestasis. Large duct obstruction. So this is the mechanical blockage of your bile ducts, either by gallstone, stricture, or a tumor, and this is usually diagnosed clinically. You will see portal tract edema, mixed inflammation with prominent neutrophils, and a bile ductular reaction, where you'll see more ducts than one in your portal tract. And you can have canalicular and or ductular cholestasis. Additional considerations: if you have lots of neutrophils in the duct epithelium or lumen, consider ascending cholangitis. And you can see a prominent bile ductular reaction with extensive necrosis hepatitis as part of liver regeneration. So look for lobular injury. So my staff likens the ductular reaction as like a process. So you have this obstruction of your bile duct. So bile can't flow and it gets backed up. Then you're going to have some injury to your bile duct. And then your body is trying to compensate because of this blockage. So that's why your bile ducts will proliferate to kind of circumvent that obstruction. Primary biliary cholangitis, which formerly was called primary biliary cirrhosis. They changed it because PBC, the end stage is cirrhosis, but not necessarily if you're well treated. And early PBC, you might not get cirrhosis. This is an autoimmune disease with destruction of intrahepatic bile ducts, usually in older women with positive AMA serology, the M2 subtype. Look for the moderate portal chronic inflammation, a florid duct lesion, where you have lymphocytic cholangitis with bile duct injury, and you can have, or not, granulomas, and it often causes bile ductular reaction and over time bile duct paucity. Primary sclerosing cholangitis. This is progressive fibrosis and stricturing of the bile ducts, predominantly seen extrahepatic, but it can have an intrahepatic. And it's often diagnosed when you do a cholangiography, where you'll see multiple strictures, and this increases your risk of cholangiocarcinoma. It's frequently young to middle-aged men and strong association with ulcerative colitis. Classically, you'll see your concentric fibrosis of ducts, onion skinning, but not often seen on biopsy. You can have a biliary obstruction pattern where you'll have edema, neutrophils, a ductular reaction, and eventual bile duct obliteration by fibrosis with ductopenia or paucity of ducts. Biliary atresia. This is idiopathic prenatal destruction or fibrosis of your extrahepatic bile ducts, and it's the most common cause of pathologic infant jaundice, and usually presents in the first few weeks of life with jaundice and failure to thrive. And your HIDA scan demonstrates failure of excretion of the radiotracer into the duodenum, where your bile normally excretes. And the treatment is the Kasai procedure and or liver transplantation. And you'll see histologically large bile duct obstruction findings. Because this is nonspecific, it requires clinical radiographic correlation. Some differentials for pediatric cholestatic liver disease include bile salt deficiency disease, formerly progressive familial intrahepatic cholestasis or PFIC, and inherited defects in bilirubin metabolism, like your Crigler, Nahar, Gilbert, among others. Neonatal paucity of intrahepatic bile ducts. This can be non-syndromic or syndromic. If it is syndromic, think of your Alagille syndrome or JAG1 mutation, and which is associated with other abnormalities like cardiac and skeletal. Micro, you'll see interlobular bile ducts absent in greater than 50% of portal tracts. And you can highlight with the CK7, which should not show anything in those absent bile ducts in the portal tracts. And ductular reaction may be present. Sepsis. Patients systemically ill, often with sepsis or bacteremia, or often jaundice. And classically, you'll have this ductular cholestasis, cholangitis lenta. However, this is challenged by some, as this seems to be common in any condition with cholestasis. You can see a ductular reaction in patients with sepsis with inspissated bile and flattened atrophic epithelium. Drug reaction. The most common histologic pattern of drug-induced liver injury is cholestasis, and you can have several patterns. You can have the bland pure cholestasis, which is cholestasis with minimal inflammation, and you can see this with systemic illness and pregnancy. You can have cholestatic hepatitis, and this is cholestasis with inflammation and hepatocellular damage, prolonged cholestasis or ductopenia that lasts greater than 3 months, and sclerosing duct injury, which is fibrosis affecting large bile ducts, kind of similar to primary sclerosing cholangitis. I'll leave this here for your review, but from here to here, the issue is the paucity of intrahepatic bile ducts. And the most common causes of neonatal cholestasis are biliary atresia and idiopathic neonatal hepatitis. And this is the clinical neonatal cholestasis algorithm that I will leave here for your reviewing, but there's biliary atresia. The procedure is the Kasai procedure. All right, altered blood flow, where you can have the shock liver. This is liver hypoperfusion of any cause, and you'll have massive elevation in AST and ALT, that up to the thousands. And you'll have central coagulative necrosis in zone 3 and collapse of reticulin plates and no inflammation. Other causes of bland central necrosis include Tylenol toxicity, where histologically it's indistinguishable. Congestive hepatopathy. This is caused by hepatic venous outflow obstruction, and this could be due to Budd-Chiari, right heart failure, and grossly you will see a nutmeg liver. Again, I've seen that on my autopsies as well. And histologically, you'll see the central zone, zone 3, sinusoidal dilation, congestion, hepatic plate atrophy, and necrosis. Chronic cases can lead to central vein and sinusoidal fibrosis, which can lead to cirrhosis. Sinusoidal obstruction syndrome, aka veno-occlusive disease. So this is sinusoidal endothelial injury, and this can be often due to chemotherapy or stem cell transplantation. And histologically, acute sinusoidal obstruction syndrome, you'll have sinusoidal dilation, congestion, sinusoidal endothelial edema. Chronic, you can have chronic central vein, zone 3 obliteration, best seen on trichrome. Cirrhosis, this is the common end of the road or end stage for many liver disorders. So it's relatively non-specific in and of itself because many things could have caused it. Histologically, you'll see these regenerative nodules surrounded by fibrosis, and you want to see both for diagnosis. There are special types like biliary cirrhosis, which is seen with long-standing cholestasis, cholestasis, where you'll have ballooning, feathery degeneration at edges of nodules, jigsaw pattern of cirrhosis. Instead of the round nodules you see here, you have this kind of irregular jigsaw-like pattern. Copper deposition in zone 1, the portal tracts, ductopenia, periductal fibrosis, and bioinfarcts. Miscellaneous. Iron overload, aka hemosiderosis. This can happen due to excess transfusions, whether you're a hemonc patient and need a lot of transfusions during your bone marrow transplantation, or iron supplementation. And iron accumulates in the Kupffer cells, which are the sinusoidal macrophages first. When those are saturated, then it deposits onto the hepatocytes. And then genetic is hereditary hemochromatosis, which due to HFE gene mutation that causes increased iron absorption and storage. Iron accumulates first in the periportal hepatocytes, then progressively involves all zones starting from 1, going to 2 and 3, and also the bile duct epithelium. And there's less Kupffer involvement compared to your iron overload. Glycogenic hepatopathy. This sequence of events is from patients with poorly controlled diabetes. You'll have abundant glycogen stores leading to hepatomegaly and elevated LFTs. It can be a component of Moriak syndrome with delayed puberty and Cushingoid features. You'll see these diffuse glycogenation of hepatocytes, demonstrated by PAS stain, diastase sensitive, and absence of inflammation. Alpha-1 antitrypsin deficiency. Genetic disorder characterized by abnormal alpha-1 antitrypsin protein synthesis. This is due to a SERPINA1 gene mutation, which is autosomal recessive, and PIZZ phenotype accounts for most cases. And this can lead to chronic liver disease and emphysema, especially in relatively younger patients, like a 40-year-old who's an active runner but then develops emphysema. You'll see eosinophilic PAS diastase positive globules within the periportal hepatocytes. Neonatal hepatitis features cholestasis and hepatocyte injury because there's too early for globule formation. And you see it in the endoplasmic reticulum by EM. Resolving hepatitis, it can look almost normal, where you'll have minimal to no lobulitis or zone 2 or portal inflammation, zone 1. You can have mild lobular disarray with somewhat disorganized plates, and you can have Kupffer cell hypertrophy, where it's acting as the garbage person and cleaning up the debris. And if you can't see it that well, it's highlighted with a PAS diastase stain. And the most common causes include acute self-limited viral infection or idiosyncratic drug reaction. adenovirus slash herpes hepatitis, you'll have massive bland azonal necrosis with characteristic inclusions at the edge of necrosis. And usually in your immunocompromised transplanted patients, and it has a poor prognosis. CMV hepatitis, just like HSV, it can appear anywhere, and that includes the liver. And this is almost exclusively in immunocompromised individuals. The inclusions can be subtle, so stain liberally if you're suspicious, and classically you'll see your neutrophilic microabscesses. EBV hepatitis looks nondescript hepatitis with mild to moderate portal and lobular inflammation. So just often keep in your differential, especially if the patient is young or immunocompromised. Classically, you'll have lots of activated lymphocytes in the sinuses, the T cells, and Eber highlights rare infected B cells. Amyloid is a part of systemic illness with often plasma cell dyscrasias, and you can have abundant amyloid deposited in sinuses. And you need your apple green birefringence on Congo red stain to confirm. Nodular regenerative hyperplasia, NRH. Think cirrhosis-like nodules, but without the fibrosis. You'll have multiple hyperplastic parenchymal nodules with normal to enlarged hepatocytes, with intervening compressed atrophied parenchyma. There should be no significant fibrosis. Remember, let's go back to cirrhosis. You can see that fibrosis right here. But in NRH, you just see the nodules, not the fibrosis, as confirmed by the reticulin stain. And this results from changes in hepatic blood flow, from obliteration of the small portal veins. That leads to localized atrophies, and the other areas grow to compensate. And this can cause portal hypertension. Congenital hepatic fibrosis. This is an embryologic ductal plate malformation that leads to bridging fibrosis with prominent malformed ducts. And the ducts are ectatic, anastomosing, and irregularly shaped, and there's no significant inflammation. You'll have few abnormal portal veins, and that leads to portal hypertension. Cystic fibrosis. This is a chloride ion channel mutation, and that results in exocrine gland malfunction. And it's fascinating where I think usually issues with the lung and pancreas, but it's also you can have issues with your liver. It's autosomal recessive, and in addition to your respiratory problems, meconium ileus or pancreatic insufficiency, in the liver you can have thick abnormal secretions in the bile duct, and that can lead to biliary obstruction, leading to epithelial atrophy, bile ductular proliferation, inflammation, leading to fibrosis, leading to biliary cirrhosis, and also you can have steatohepatitis. And the secretion is stained with PAS diastase. And here is Dr. Schaber's lab correlation. So the big take-home points: HBV, ground glass inclusions, AIH, autoimmune hepatitis, plasma cells, adverse drug reaction, lots of presentations. Most common is cholestatic injury. Cholestatic, you'll have elevated alk phos, GGT, plus or minus bilirubin, jaundice. Think about your primary biliary cholangitis and primary sclerosing cholangitis. And for chronic hepatitis, 5% of people with HBV could develop chronic hepatitis. Autoimmune hepatitis, think about your interface activity, necroinflammatory lymphoplasmacytic infiltrate, your anti-smooth muscle antibody, ANA. Hep C, 80% develop chronic hepatitis. Look for your nodular aggregates of lymphocytes. Hereditary hemochromatosis, HFE genetic mutation, elevated transferrin saturation and serum ferritin. Wilson's, increased liver copper, ATP7B gene. And alpha-1 antitrypsin deficiency is PIZZ. The hyaline globules are positive with PAS diastase. Alcoholic can look like steatohepatitis, but look for numerous neutrophils and mallory denk bodies. And then regardless of the etiology, if it keeps on being prolonged and there's continued injury, it'll lead to cirrhosis or liver failure. And then more differential diagnosis, I'll leave this here for your review. Okay, well, thank you if you've been with me till the end, thank you. We've been on a journey. this journey of medical liver, and it's a very arduous journey indeed. But Dr. Schapper guides us really well. And before we stop, here's our my last minute reviews. So steatosis, steatohepatitis, both are the same disease process, but steatohepatitis will lead to fibrosis faster. To call steatohepatitis, look for your balloon cells and your mallory denk bodies. Fibrosis, fatty liver disease, causes first pericellular and pericentral fibrosis first, then progresses to zone 1, portal and pericentral fibrosis, and then bridging fibrosis, and then cirrhosis. Alcoholic hepatitis, look for more quantity in hepatocyte ballooning, more neutrophilic lobular inflammation, more mallory denk bodies, but it can look identical to NASH. And then NASH, this is your grading based on fibrosis, steatosis, lobular inflammation, and hepatocellular ballooning. Wilson's disease, the histology is variable, but serology, you'll have low ceruloplasmin, increased urine copper, you'll have mutation of copper transfer ATP7B, and clinical findings as well, your bronze diabetes. TPN, you can get cholestasis, steatosis, steatohepatitis based on your age. Drugs can cause macrovesicular along with malnutrition, hormone changes, cystic fibrosis. Microvesicular, that's due to, make sure it's diffuse to call it, and it's a sign of mitochondrial damage. It can be due to Reye's, inborn errors in metabolism, drugs, toxins, acute fatty liver, pregnancy. Portal tract chronic inflammation, zone 1, chronic hepatitis C. Look for your portal lymphocytic infiltrates, periportal interface, portal lymphoid aggregates. Chronic hepatitis B, look for your ground glass inclusions, along with your portal chronic inflammatory infiltrates. You can have a variant called fibrosing cholestatic Hep B, which has more of a worse prognosis, and you'll have extensive cholestasis, bile-ductal reaction, hepatocyte swelling, and fibrosis. Autoimmune hepatitis, strong in females, elevated AST, ALT, often marked, anti-smooth muscle antibody, along with elevated IgG. Look for your interface activity with lymphs and plasma cells, along with your regenerative rosette formation. Graft versus host disease, you'll have bile duct epithelial injury, you'll have the withering and dropout of the bile ducts, and you can have mild portal inflammation and possible endothelitis. Rejection, there's T-cell mediated, where you have mixed portal tract inflammation, including EOs, bile duct damage, and endothelitis. Plasma cell rich rejection, it's got to be greater than 30% in the portal and the central vein. Make sure to rule out prior history of autoimmune hepatitis. Chronic rejection, you can have chronic vascular damage with foam cell arteriopathy and luminal narrowing. Antibody mediated rejection, get your C4D showing greater than 50% staining of vein and capillaries. And you can have portal vascular dilation, endothelial hypertrophy, and arteritis. Lobular injury, your zone 2, acute viral hepatitis. Diagnosis is confirmed often with serology or serum PCR, but you'll have lobular damage and disarray, diffuse lobular inflammation, hepatocyte ballooning swelling, hepatocyte necrosis, and regeneration. No fibrosis. Drug reaction, idiopathic neonatal hepatitis or neonatal giant cell hepatitis. Lobular disarray with giant cell transformation, absent to mild lobular inflammation, canalicular and hepatocellular cholestasis, minimal portal tract changes, and preserved bile ducts. Diagnosis of exclusion. Rule out biliary atresia. Cholestasis biliary, you'll have elevated alk-Phos, GGT, serum bilirubin. Highlight bile ducts with your CK7 or CK19. Large duct obstruction, portal tract edema, prominent newts, bile ductal reaction. If you see newts inside the duct epithelium or lumen, consider ascending cholangitis. Primary biliary cholangitis, older woman with positive AMA serology, look for your florid duct lesion. You can have granulomas, and it can cause bile ductal reaction and bile duct paucity. Primary sclerosing cholangitis, progressing fibrosis and stricturing of the bile ducts, predominantly seen extrahepatic but also intrahepatic. Look for your string of pearls on cholangiography, increased risk of cholangiocarcinoma, and it's the onion skinning. Biliary atresia, help diagnose using the HIDA scan. The surgery is Kasai procedure. Neonatal paucity of intrahepatic bile ducts can be syndromic or non-syndromic. If it's syndromic, think about Alagille syndrome, which is due to a JAK1. Your interlobular bile ducts is absent in greater than 50% of portal tracts. Sepsis can have ductular cholestasis or ductular reaction with inspissated bile. Drug reaction, the most common histologic pattern of drug injury is cholestasis. Altered blood flow, look for shock liver, central zone 3 coagulative necrosis without inflammation. I could also histologically look identical to Tylenol toxicity. Congestive hepatopathy, your nutmeg liver, look for, can be due to right heart failure, Budd-Chiari. You'll have central zone 3 sinusoidal dilation. Sinusoidal obstruction syndrome, it could be acute or chronic. Acute sinusoidal dilation, congestion, sinusoidal endothelial edema, and chronic central vein obliteration. Cirrhosis, this is the end-all be-all for various processes, and you can have special types. Iron overload, hemosiderosis, more iron in the Kupffer cells. Hereditary hemochromatosis, more iron in the hepatocytes. Glycogenic hepatopathy, diffuse glycogenation without significant inflammation. Alpha-1 antitrypsin deficiency, SERPIN1 gene mutation, autosomal recessive. The PIZZ phenotype accounts for most cases. And you'll have eosinophilic PASD positive globules within your periportal hepatocytes. Resolving hepatitis looks almost normal, some lobular disarray, Kupffer cell hypertrophy. Adenovirus or herpes hepatitis, massive bland azonal necrosis with inclusions at the edge of the necrosis. CMV hepatitis, almost exclusively an immunocompromised. Look for your neutrophilic microabscesses. EBV hepatitis, nondescript hepatitis, lots of activated lymphocytes in the sinuses. And EBER highlights rare infected B cells. Be suspicious. Look for your demographics of young or immunocompromised. Amyloid, get your apple green birefringence on Congo red stain in patients with often plasma cell dyscrasias. NRH, cirrhosis like nodules but without the fibrosis. Get your reticulins to confirm, and often due to changes in hepatic blood flow and compensation. And it can cause portal hypertension. Congenital hepatic fibrosis, embryologic ductal plate malformation with prominent malformed ducts, and the ducts are ectatic, irregularly shaped without significant inflammation. Cystic fibrosis, you'll have thick abnormal secretions in the bile ducts. And this could lead to biliary cirrhosis and also often steatohepatitis. And the secretion stained with PAS diastase. Thank you so much for watching. Thank you to Dr. Schaberg for his excellent notes as usual. And we'll catch you next time on Pathogonia. Bye.